Dr. Lakshmi? Yeah.
Can you see my slide?
Yeah.
Yes.
Uh, First of all, thank you, Dr. Namrata. Thank you, Dr. Mahil, for putting up this very nice program at short notice. And I know it's not easy to do that. And all the topics are very nice. And Dr. Iravati has really covered a very vast number of cases. And almost all the spectrum of trauma has been completed in her study. Mine is, of course, complex orbital injuries, but I saw one query in the WhatsApp group where Dr. Iravati had asked whether her fellows and PGs could log in. Then I realized that let me not make it really very complex and try to cover some basics. Blunt and penetrating trauma to the orbit can have a devastating effect. If you ask me between the two patients, the one to the left who had a blowout fracture was extremely upset and very, very down after the injury compared to the one to the right. She's smiling there. Blood fracture, you can have a complete ptosis, not necessarily a third nerve palsy, which does take some time to clear up. But of course, a very good imaging, and there you have to cover the brain as well. Even in orbital injuries, it's always better to have a good coverage of the brain. Many a time they will have a brain scan, in which case you will have to have an exclusive orbital scan. ABC is the essential of any trauma to the eye because it can be penetrating, it can be blunt. You should realize it's a part of the face and the head. So injury to the brain is very likely. Airway, breathing, circulation has to be established in every case of orbital or ocular trauma. There can be shock, there can be head injury, there can be a cervical spine trauma as well, which again has to be looked into. Penetrating injuries should be suspected whenever there's history of trauma in the region of the eyelid. Now, this patient was not very sure. He was in the army, but he was not able to tell us. But then when we imaged him, he was only worried about his ptosis. We saw a small scar here, and later on, I don't have his scan photos. He had a bullet in the apex of the orbit. So we had lost his vision. He had come mainly for ptosis repair. So meticulous inspection is very important because many a time these are medico-legal cases, road accidents, child abuse, etc. Now here there is a iris prolapse. So debridement is the key when you're taking them up for repair. You should give a thorough wash with saline and of course an alkali burns also you give a thorough wash. You have to give a thorough wash. Supposing the tissue is only not viable at all, then you may be able to trim it. Be very careful when you trim tissues because it's always very nice to trim all the tissue which you think are not viable, but they will, to your surprise, every millimeter of tissue is very essential because repair is more important. This is not the time for you to take graft. So primary repair is the initial importance here, is of importance here. So history is again very important. Medico-legal issues, alcohol abuse, abuse of child, because children may not come out in clear detail about the nature of injury. Look at the margin, and as oculoplastic surgeons, canalicula's, because you may have done a beautiful repair, you may have even put in an implant initially, but if you have a nasolacrimal duct compromise, you're going to have recurrent infection, and whatever you have done goes down the drain. So whenever you see fat in eyelid injuries, which will be covered later by my other colleagues, you have to suspect a deeper injury. And I also mentioned already about the documentation and medical legal issues. 3D imaging is invaluable in cases where there is associated brain injury, and if you're seeing the patient later, imaging such as CT cysternography, where you will see CSF leak, is very important. A conservative treatment, especially at the apex of the orbit, the eye is not moving, but luckily the vision is good. Whether you want to go, if the vision is good, you will think twice, thrice, 100 times whether you want to go and meddle with this small piece of bone, because you know you will need a cranial approach, and whether you can compromise the vision further. So here it is better to be conservative. But if the patient has lost vision and comes in the early period, you can explain the pros and cons and consider decompressing the piece of bone which is impinging on the nerve. Here it is not much of impingement, but sometimes you will see a direct impingement on the nerve where it would be worthwhile decompressing. I still, for orbital fractures, it's better to give conservative treatment for at least about a week or two. Give them antibiotics, give them steroids if required. See whether there is traumatic optic neuropathy. IV-IMPI definitely has a role, at least in our setup. If it definitely has a role to play, we'll talk about it another time in more detail. Children, it behaves like a green stick fracture. Wait for the hematoma, but again, please try to evaluate the pupil at the earliest because you don't want a traumatic optic neuropathy in a child. They will not be able to tell you about the loss of vision. Fall from a crib, from height, or from the parents' arms, or etc. can be very difficult because parents will be very anxious. But again, you have to carefully explain and keep them under. If necessary, you have to review these patients every day. This was a 1-year-old child fallen from a first floor or second floor. First of all, it was a wonder that he was alive. There was no loss of consciousness. That was another big wonder. He had only a superior wall and a frontal bone fracture, superior wall of the orbit. The neurosurgeon didn't want to intervene. They said, we'll wait, but this looked totally unviable. I was almost wondering whether I should go in, but the neurosurgeons wanted to also give in some time. So I decided I'll give IV steroids and antibiotics and bring down the edema first. And to my surprise, a week later, the eyeball was absolutely intact. It was what was seen was the prolapsed conjunctiva. So you have to be very careful. And under anesthesia, I evaluated this child, and a month later, the child had good vision also. So when there is associated head injury, primary repair is the key. As much as possible, no grafts, no skin grafts. You can use collagen, and there are so many other devices which we can use when you work, especially with the plastic team, which can help regeneration of the skin. Please wait. Now, when there is a superior wall fracture and there's dystopia or other wall associated fractures, it's better to explain that some amount of dystopia can remain, but this patient was reluctant because of the superior wall. He said, if you want to do there was hardly any medial wall of flow. Generally, I don't touch the medial wall because it's better not to intervene. Whatever you do, the bone is so thin there, and you try to keep something there, it will just fall off into the sinus or into the nasal cavity. So if it's an isolated medial wall fracture without any impingement on the medial rectus, I would like to wait. But of course, again, if there's traumatic optic neuropathy, it is worthwhile to decompress. So you must explain to the patient about dystopia. If there's a lot of ecchymosis, again, you give conservative treatment, allow the edema to settle down. And in these cases, if there's associated brain injury, please look for a pneumocephalus. This will be cause for a CSF leak later on. So stuffy nose, when the patient bends down, sometimes drips of fluid coming down from the nostril, or a very stuffy nose, or some kind of headache, confusion will indicate early meningitis due to a pneumocephalus, because the dura will be torn there and the brain will be communicating with the sinuses. So its chances of infection are very high. In children, I said also it's better to be conservative, but you have an isolated green stick fracture like this, sorry, not a green stick, trapdoor fracture like this with troublesome diplopia. And if the eye is quiet, we generally call this as a white blowout fracture, you can undertake early repair. Omnipore and Medpore is my choice. Nowadays, it's called Omnipore. Barrier implants are my choice. And when you have fracture with loss of light, please repair the fracture first before you put in an implant. This patient, I put in the implant first, but later realized the cosmesis was not good. So try to repair the fracture first, then put in, and in case the tissue planes are well maintained and you can put both in the same time together, but it is better that both implants are not touching each other and communicating. This patient, I did the fracture repair first, followed by the implant surgery later. Tripod fractures, you need the help of a plastic surgeon. And here, when there are neurological frontal bone fractures as well, make sure there's no CSF leak before you undertake any form of repair. And the scars can easily be managed. You don't have to give 5FU, nothing, just good massage with silicone gel sheets will do wonders for the scars in the initial period. Okay. As I said, I like porous polyethylene the best. I've done about, until 2018, I had between for about 8-9 years, I've done about 38 cases. Generally, the timing of surgery, luckily because I was that time in Manipal, and even now I get fresh cases. But most of the time when I was in Shankar Netralaya, they come usually at the end of 2 to 3 months. The facial-maxillary surgeons would have already intervened, or the neurosurgeons would have intervened. There will be troublesome diplopia, severe enophthalmos. And so for me, there have been no problem with porous polyethylene. And when you debride the fracture and decompress and put in the sheet, you see how beautifully the sheet is sitting. This is the bone which had gone in. This is the sheet. And the mesh, I'm not very fond of these titanium meshes. I generally call mesh a mess. It's a real mess. Unless you have released the muscle fully, no point in putting this mesh because the mesh will continue to trap the bone. So if you're putting these, it's better. You can use porous polyethylene with titanium. Those meshes are available. They have very good results. So please make sure that the muscle is fully released and not like this. So this patient came about 2 3 months later with troublesome diplopia. So once again, a large fracture in a young patient. And actually, for some time, I was not getting
Dr. Lakshmi, please conclude.
Yeah, I was not getting Medpro, so I was using Omniport. Sorry, our Indian Medpro, which is surgery from surgery. I don't know financial interest. They did very well. Sagittal reconstruction is a must in every case of orbital fracture, and you must explain that enophthalmos can also remain when they come, especially in the later stages. So some complex cases, sometimes the eyeball would have sunk into the maxillary sinus like this. You have to just release it and put it back. Sometimes you'll be very surprised that the patient can regain very good vision. Ultimately, it's all a question of rehabilitation. Thank you very much.